Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
What do you have today? I already started recording, so we're good to go.
Awesome. All right. Well, today we have a 68-year-old gentleman, relatively healthy, depression on Lexapro, stable dose for decades, symptomatic cholelithiasis, but never cholecystitis. He actually has an upcoming elective cholecystectomy, actually this week. And then no other past medical history until last week when he was admitted with an E. coli pyelonephritis, bacteremia, severe sepsis. But because he was, he's healthy going into this, he was relatively short hospital course, maybe like 4 days, IV antibiotics, and then sent out to complete a 7-day course, oral. He's now coming back literally less than 48 hours later, brought in by his 3 kids and his wife from home, sort of frantic and panicking, saying that he's had this acute progressive altered mental status over the last like 36 hours, but they're pretty clear that he came back normal from the hospital, that day of discharge. I have a lot of data for you, but I was wondering, since we talk about altered mental status frequently, I'm wondering in this case how that recent hospitalization maybe changes your differential or the frame of the case. Just kind of broad strokes thoughts, because AMS is just such a broad
Yeah.
problem.
Yeah. We started a case with was it pyelonephritis, the IgG4 case? I'm like I'm struggling now if it was just AKI or pyelo.
Yeah, that was
Yeah.
AKI, I think, but then you got to the pilot pretty quickly. Yeah, but it's a
Oh,
little
okay.
similar.
There,
It has
yeah,
some
yeah,
similar
yeah.
strains.
The recent Pylo case coming back to the hospital strikes again. So, um, yeah, I think for any problem for a patient coming back to the hospital after having been to the hospital recently, our brains really want to go to tying that problem to that recent hospitalization, meaning blaming something that happens in that hospitalization. Is this something that represents kind of the natural evolution of the disease that caused the patient to present to the hospital? So for this patient, is this another complication of untreated pyelonephritis? Or is this something that we kind of did to the patient in the treatment of pyelonephritis, or do we make some sort of medication change to the chronic regimen this patient's on, which it sounds like this patient's really on nothing, just Lexapro, that kind of could have triggered this? So we don't really have much for the latter issues in terms of the latter hypothesis that is brought out because this patient isn't on many medications. So I guess it's just worth considering what could have happened if this is just pyelonephritis that's gone on and on and on. It's hard to kind of entertain that hypothesis though when you consider that the only reason I can think of for treatment failure for pyelo is there was like a source control issue for this patient. Like, was this a result of nephrolithiasis, just like this patient has stones in their gallbladder? Do they have stones in their kidney and there's interval kind of blockage of a ureter, and that has led to kind of pus under pressure and a profound kind of SIRS response that's leading to a what could be global encephalopathy. We haven't characterized the patient's altered mental status, and I wanted to talk about that at the end. But is that something that happened, or is this somebody that we discharged from the hospital without having um, finalized susceptibilities for the bacterial culprit of that E. coli, and we put them on inappropriate treatment? But that would be really odd, I would say, for this patient, because you told me that they got better and they were kind of discharged at their baseline. So that's not really part of the natural history of pyelo in my mind if they were getting treated correctly. So, you know, in the absence of this, so what workup would we do for this sort of situation? We would get vital signs for the patient coming back to the hospital. Like, are they newly septic? Do they have fevers? We would get these standard rainbow labs on the CBC. Do they have a new leukocytosis with neutrophilia that would signal that there's uncontrolled bacterial inflammation in the kidney? And we would get a BMP and we would get LFTs. The BMP would tell us if for whatever reason the kidney function intervally got worse, because of course, if your kidneys go down, you collect toxins in your bloodstream that's signaled by the BUN going up. And that, of course, can provoke a global encephalopathy with metabolic encephalopathy. The LFTs, of course, would tell us if there was something like a DILI that developed from antibiotics going back to new drugs provoking this change. Certainly, if this patient developed like a hyperacute change in LFTs with very, very high AST, ALT in the thousands, you can imagine if the liver goes down, you can have impaired clearance of toxins too. Does this patient have asterixis on exam that would signal that? Asterixis is not a specific sign for liver failure. Asterixis is just a sign of kind of toxic metabolic encephalopathy. You can see this from renal failure too. So what I just mentioned a second ago, you could see it from hypercapnia, which would be odd in this case. This patient doesn't have risk factors for hypercapnia, but that would point you in that direction even before you get labs. Um, so I think for the workup, just to summarize, for complications of recent pyelo for this patient, it would be the Rainbow Labs vital signs. If you think it's indicated at that point, after getting further history, I suppose you can consider blood cultures. It sounds like this patient, it was bacteremia, Mike? They had bacteremia, or it was just okay.
That's right. Yeah. So they had it in the urine, imaging findings of pyelonephritis, and then bacteremia.
Got it. Okay. Um, and then I think our job is really just to talk to the family a little bit more to characterize the encephalopathy. Because in my head, this is someone who's probably a little bit more like hypoactive, meaning they're like inattentive, sleepy, slower to respond. These are really the hallmarks of global encephalopathy, which you see from these toxic metabolic causes. But you just don't want to miss an encephalopathy that's more marked by focal findings like behavioral issues, agitation, psychosis, because these are really more subtle kind of focal findings, really, that could signal something going on within the brain focally. And of course, that's a whole different problem to solve. So, yeah, maybe I'll pass it off to you, Mike, and hear kind of how they landed and what you heard from the family and the initial data.
Sure. Yeah. I think I'm going to give you all of that and hopefully not an overload here of data. So he comes in, temp is 99.5, heart rate in the 60s, respiratory rate. He's a little tachypnic, 20 to 22. And he's actually pretty hypertensive, 185 over 88. He has no hypertensive history. And you look back at the prior hospitalization, and there was never a hypertensive blood pressure documented, albeit he was septic. Home meds, Lexapro, as I mentioned. The labs on the day of discharge, so about 48 hours ago, he had a CBC with a mild normocytic anemia of 11.6. He actually came in with a baseline of 14. It was felt to be dilutional because of all the fluids he got. And BMP was truly unremarkable. LFTs truly unremarkable. I mean, there were no changes. His baseline creatinine is zero point 0.6, and it was at that baseline. He's coming in now. He does have a leukocytosis with a pretty strong left shift, leukocytosis of just 12, but 90% neutrophils and some bands are appreciated. Hemoglobin's now 13. Platelets are actually 90, but on a recheck, 155. So I'm not sure that that's normal, or excuse me, I'm not sure that that's real. He's a little hypernatremic at 146, a little hypokalemic at 3.6. He has a mild non-anion gap metabolic acidosis. Bicarb is 20, gap is 8. And creatinine is at baseline still 0.62 from a baseline of zero point 0.6. Phos is a little low, 2.4. Liver chemistry shows normal T-billy, normal alk phos, but an AST that's now 112 and an ALT of 125. These were again normal 2 days ago, 3 days ago. And I guess I'll just give you some more history then, as well as because now we always see these patients in reverse, right? You see the chart before you see the patient, but so the history really is that he came home looking well, and then sort of through the day, kind of like you mentioned, it's hypoactive. That would describe sort of the initial sort of changes. Spending kind of the rest of the day in bed. a little inattentive, but then actually very interestingly is, by the evening of the first night home, like breaking down in tears, so perseverating on sort of, um, terrible things that have happened to people I love, and just sort of this like, um, not necessarily maybe not delusions, but certainly perseveration. And it's not clear if the things he's talking about are reality or if they're something that's sort of a figment, unclear. Um, sleeps very poorly that night, sort of more maybe agitated to some degree. Um, and sort of wobbly a little bit on the feet. Sounds like he's pretty unsteady. They actually kind of ask him to get back into bed. And then the next day, he's, according to them, quote, a basket case, just sort of uncontrollably sobbing and almost even making some mention of like self-harm. Doesn't quite go as far as suicidal ideation and sort of like I'm at the end of my life, just let me go. Remember, this is like a 68-year-old guy who, a couple months ago had no major past medical history. He's a elective surgery coming up for some pain he gets sometimes, but nothing else. And finally, like this morning, so now, the third morning away from discharge, they said, this is not him. This is crazy. We've been giving him his antibiotics. He's not any better. The patient really cannot give you any history at all. He's kind of as described. He's crying throughout the exam, head in his hands, shaking his head. Does make kind of comments about, I'm at the end of my life, just let me go, who cares? Those sort of things. And I mean, it really does. He seems sort of depressed. Actually, we end up having to talk to psychiatry, asking them to come by and just say like, hey, do you guys I think this is text metabolic, but can you guys just confirm that we don't need a sitter or something like that, right? What's this sort of a safety evaluation? And on exam, he's really not cooperative to much. You can see that he's moving all of his limbs, and you do see that he ambulated from the bed sort of to the bathroom and back because you kind of caught him on his way. The gait is sort of unsteady, but I don't know that you can notice any sort of illness script in the gait necessarily. And then when he gets back, he just is not communicative. He is saying things, he's crying, and he's saying all of the statements I mentioned, but nothing else. And then exam otherwise, what you can get of the cranial nerves seem to be grossly intact and symmetric. And he really, the only other thing is just abdominal pain or tenderness, I should say, because he doesn't actually report pain, but you notice that he's pretty diffusely tender across the whole abdomen. And that's really it. That's all you got. His cardiopulmonary exam, other than maybe a little bit of a flow murmur. He's not even tachycardic though. No edema anywhere. And that's it. So I'll stop there and see if there's anything else you want. But I thought that that was a really fascinating presentation for me, and I'm wondering your thoughts on that.
Yeah, you're such a good storyteller, Mike. I feel like I'm right there at the bedside examining the patient. There's a tension here. There's a tension because we have the objective data of neutrophilic leukocytosis and a tender abdomen. Of course, in a patient with encephalopathy, that makes the kind of fidelity of that information kind of hard to interpret. But I think we're really obligated in the setting of a recent sepsis with bacteremia to treat that seriously. So I don't think we put much cognitive effort into that. I think we just send them to the CT scanner with IV contrast and look for acute intra-abdominal inflammatory pathology. So is there like a perinephric abscess that needs to be drained? Are we going to see the kidney stone there that we already talked about? Is this now symptomatic cholecystitis because the patient has cholelithiasis? The transaminases were mildly elevated. I don't love on first pass attributing mild transaminase elevations to cholecystitis because, as we know, garden variety cholecystitis doesn't cause transaminases to go up. Your gallstones get wedged into the cystic duct and not the kind of common biliary duct, CBD. There we go. I always call it CBD. So unless if it's doing that, it really shouldn't cause the transaminases to go up. There's also the Maritzi syndrome where the cystic duct can get so inflamed that it compresses the nearby CBD and cause the AST and ALT to go up. So it's like a bit hard for cholecystitis to do it. But in any case, like the CT scan is like a pretty good test to assess for all of this. But I think the tension here is that I was talking about characterizing the encephalopathy, and while things started hypoactive, he's pretty hyperactive, and it sounds like he's having a lot of kind of behavioral disturbances with the agitation, like you said, and perseverating on things that aren't there. At the same time, I think we have to consider, is there a strategic stroke or a seizure that's going on in the brain to kind of account for that peculiar symptom complex? Because again, garden of variety toxic metabolic encephalopathy, which in a setting of infection, like we're entertaining for hypothesis number one, I call that para-infectious encephalopathy. It's really more hypoactive, sort of delirium, hypoactive findings. So I have a list for strategic strokes and seizure locations that can cause kind of these more hyperactive and behavioral symptoms. And this comes straight out of Aaron Berkowitz's neurology clinical reasoning text. So, first of all, inferior division at right MCA, super specific. This can cause self-awareness and attentiveness issues. Hippocampus lesions can cause amnesia, and thalamic lesions can cause arousal and memory issues. And just adding to this, I think other parts of the frontal cortex can cause a kind of psychosis and agitation as well. I don't know this anatomy very well. Yeah, I'm reading it off of my notes right now. I think at the end of the day, what we're entertaining is the idea that this is a strategic CNS lesion and this patient would be out of the window for the stats stroke workup. So this patient, I wouldn't send like straight to the CT scanner. I think if we don't find anything on intra-abdominal imaging, or if we do, but this behavior stuff kind of remains and it's not getting better, I think then we would just go straight to an MRI of the brain to try and see if we can uncover something. And the idea of seizure too, seizures can provoke these sorts of changes too without loss of consciousness. So we could talk about throwing on EEG too. I guess it's just a little hard to invoke that without kind of a substrate for seizure in a patient who doesn't have a known unprovoked seizure disorder. So I'm like on the fence on doing it. There's really like no harm in getting an EEG. So sure, on the podcast I'll like throw it on. Let's get EEG while we're waiting for the MRI brain too. But yeah, I'm kind of first curious about where the abdominal workup goes, and then we can kind of tie in the clinical course in terms of those findings to see how the brain kind of syndrome evolves.
Sounds great. I love that. I think always the push and pull of someone who comes in encephalopathic, particularly on the internal medicine service, right, is like, is the brain angry because the body's sick, or is the brain sick itself? And I think that's like one of the hardest things. I still struggle with that. It's helpful to hear your framework for it. I'm just going to give you another dump of information, and you can tell me to go back or stop.
Mike's
Um,
dumping all the information because the last two episodes I presented to him with that info dumps. So it's fair game now.
I'm getting you back. Yeah, yeah, yeah. So he gets in the ED, he gets a CT head non-con that shows some mild paranasal sinus disease, some chronic microvascular stuff, but nothing else. Um, Chest X-ray, truly normal. I mean, textbook normal on looking at it yourself. For some reason in the ED, he got a CT AP without contrast. That shows urinary bladder distension, minimal bilateral perinephric stranding, which is similar to the prior CT, which was contrasted, the prior admission, and mild to moderate extrarenal pelvis, ureteral and bilateral nephroureter prominence, but not hydronephrosis. Nothing sort of hedged their bets there. And then they said this tubular appearance of the left colon could be due to incomplete distension, possibly nonspecific colitis. Other findings described correlate clinically. Um, I'll just give you the labs in addition to that. So ethanol's negative, TSH is within normal limits, 1.62, lipase is negative, lactate's negative. INR is 1.4, which is a little high for a guy who doesn't, he's not on blood thinners. Trope negative, UA was negative now. It had been positive the last admission. And then I'll just let you see into the future a little bit. His urine cultures and blood cultures never grow anything. He had pneumonia level checked for some reason, which was low. Expanded tox screen was also negative. He had an extended RVP, which at our institution actually shows atypical bacteria as well. That was negative. He had a stool PCR sent, which was negative. And then procal 0.26, which is kind of like that borderline on our assay of where whether or not you really consider it positive. B12 normal 661. And then because of those AST, ALT elevations, he had some hepatitis stuff sent off, it looks like, and hepatitis B immune. And actually, they got an RNA, which was negative. HCV looked to be negative as well. CRP is 84, which is higher than the discharge CRP. ESR is 48, which is just mildly high. And he did not have he had a negative ESR actually last admission, interestingly. Mercenaire's negative. And then just because, obviously non-con is underpowered, right, for Pilo, so he actually did get a contrasted study when we saw him the next day. And for that one, this time there's no hydronephrosis. There's actually no perinephric fat stranding, no lymphadenopathy, no hydronephrosis. The urinary bladder is now decompressed. He did not get cathed. He did not get a Foley. This just kind of, he just had to pee, I guess, when they got the scan. Um, and yeah, they said the heterogeneous enhancement of the right lobe of the liver near the periphery, likely related to vascular abnormality in this area, seen on prior CTs going back. And they mentioned like 2014 or something, like over 10 years ago. It's been there. And then no lymphadenopathy, no, lytic or blastic osseous lesions. It's really read as a negative scan, as a normal CT, because of the mild AST ALT elevation and this history of basically getting a cholecystectomy this week. We got a HIDA as well, which was negative for acute cholecystitis. He was initially on ceftriaxone, which was basically just the equivalent of his oral antibiotic and a continuation of the ceftriaxone last admission, for which the E. coli was sensitive. It was pan-sensitive. And he's not any better. So the next day you come in, this is now your second day with him, and he's significantly worse. So families all around bedside, they're very involved the whole admission, and they're sort of like, doctor, talk to me. Uh, you know, their loved one, the patient, is in the bed, the room's dark. He's like kind of just in the fetal position, turned up facing the wall. He's not talking to us. His eyes are closed. He doesn't follow any commands. He's just kind of mumbling. Family says, he's not saying, self-harm things anymore because he's not saying anything. You can see sort of tears in his eyes still. And, again, your exam, you can't get any kind of meaningful neurologic exam. You do pull open the eyelids to make sure the pupils aren't different and, they're normal pupils. And his abdomen is still pretty tender. But that's it. That's all you got. You got nothing else. You can't really get him to move his head in a way that you can tell if his neck's tender or not. But it doesn't appear to be, best you can tell. I mean, he is sort of crunched in a fetal position, which you imagine would stretch the meninges. But that's it. That's sort of the exam. And I guess I'll also just give you that, you started him on ceftriaxone. Overnight, he was actually broadened to Zosyn. Concern, of course, being that actually, excuse me, he has a penicillin allergy, so he's brought into cefepime plus metronidazole overnight for abdominal sepsis. And this morning, so when he came in, his white count was 12, and this morning his white count is now 24,000. I'm going to pause there. What do you do next?
Wow, this is really tough. I think the tension, the aliquot is the patient's still really uncomfortable in the abdomen, yet we have a very high fidelity CT scan now with IV contrast kind of saying the belly is fine. So, again, acknowledging that the patient is so encephalopathic now that kind of the history is tough. I think we still want to take the abdominal complaint seriously. So, when I think CT negative abdominal pain, I think of a couple of different buckets. And just because I don't want to miss anything, because I think this may be a crux of the case, I'm just going to pull up my notes on abdominal pain because I have a precise framework for this moment. What we've already passed is kind of the life-threatening visceral stuff. Taking a step back and looking at the abdominal wall. We had an abdominal wall case with a abdominal wall hematoma a couple episodes ago. could this be someone who has abdominal wall pathology? It sounds like you examined their belly and didn't see anything on the belly. So if you don't see any masses, there are some entities like acnes, just nerve entrapment of the belly that can cause severe pain. But of course, that driving an encephalopathy in this case doesn't really make much sense. And I'm like looking at this list here, and really none of the abdominal wall syndromes really account for the brain stuff at the same time. So really what we move on to is the clinical problem solvers framework for image negative abdominal pain. And, the toxic metabolic stuff, I think, does come to the forefront here because of the brain issues that are going on with this patient. I would say since this is someone who's coming in for the very first time, it's hard to invoke something that's intermittent like porphyria, but I do think of a porphyria with abdominal pain, encephalopathy, and nerve pain. So I don't know much. I have a robust script for porphyria, and I have to look at the triggers. I know triggers are a very important aspect to the diagnosis of porphyria, and uncovering did this patient get exposed to something recently that could have triggered this. I would definitely be looking that up since the syndrome is really unexplained image negative abdominal pain and a neurologic symptom. There are a couple other ones to keep in mind, like lead poisoning can cause encephalopathy. It usually come in with a pretty profound microcytic anemia with hemolysis, which you gave us the hemoglobin was higher than usual. So that's probably not the case here. Profound metabolic issues like hypercalcemia can do this, but of course we get the BMP that doesn't show this. Adrenal insufficiency can cause abdominal pain, and that's image negative, but this patient's hypertensive, not hypotensive. And yeah, everything else on this list I'm not going to go through just because I don't think it really ties into the profound encephalopathy that we're seeing. So what I'm really digging for in the abdomen is something that can cause the encephalopathy. Because I think the issue with this is they have depression, and I could see a lot of people wanting to reach for depression as kind of like, oh, they're just having like a profound depressive symptom. But my wife would kill me if I told her we didn't do the full workup. She's a psychiatrist. You have to do the full workup before you invoke that in somebody. And of course, they have a skyrocketing white count as well. I will say this for very high white counts, the differential, of course, other than just run-of-the-mill bacterial infections, C. diff is a particularly predominance entity that can cause pretty high white counts. And, inflammation of the GI mucosa often does show up for C. diff, but it need not be positive CT scan. Like you could still have like luminal ulcers like on a colonoscopy where you can see it with a camera, but the CT scan doesn't light up and you're still developing this profound inflammation in the inside of the lumen, and it's just not causing a lot of bowel wall thickening on CT scan. We didn't hear much about diarrhea though, so that would be pretty odd because usually it's still going to cause some amount of diarrhea. But I would be thinking about that as just the complication of the antibiotics the patient got, since the timing of this was after the antibiotics. But no, I mean, beyond that, I'm having a hard time finding a synthesis, and I do still want to solve the problem separately too. The CT scan doesn't tell us anything other than they didn't have a large stroke and a large hemorrhage. So I think at the same time, I can't reconcile the skyrocketing leukocytosis with like a stroke. I think it's a little weird. Like ischemia in the body can trigger profound white counts, like if it's in the gut or in a lung. But the brain, as far as I'm aware, doesn't generally cause that. So I don't think we can say that's related, but I would, just because I'm confused, I think solve this brain issue separately since they are so different. Of course, at the same time, since the brain is really going down so profoundly, if nothing's on the MRI, I suppose at this point, we've exhausted all of the kind of extra CNS causes of encephalopathy if we don't find anything for this image negative abdominal pain workup. And we're really tied to an LP at that point and kind of doing the routine infectious workup. But yeah, how did things progress after that with your interval workup, Mike? Because I guess my final answer for next steps, because I feel like we're getting close here, is MRI brain, plan for LP, um, do a quick chart review on triggers for porphyria to tie everything together. And I don't think I have anything else like toxic to kind of tie everything together. So I think I may solve it separately.
Okay, yeah, that's exactly, I think, where the crux was for us too, Andrew. Do we pull the trigger on MRI LP, which I feel like is common internist problem of someone who's septic without a source, who's very, very confused. Because it's the worst thing to miss, but I've diagnosed it so infrequently. So yes, so he does get an LP and an MRI, and we actually start him on full meningitis coverage with AMP, vancomycin, ceftriaxone actually, because we think that Pseudomonas is pretty unlikely, and acyclovir. He is still on metronidazole because there's still this like lingering concern for abdominal sepsis that we haven't found, because of just the fact that this abdominal pain is the only thing we have. So the MRI we get first. And I should say that this is a really tough day. I mean, he has to go down for MRI 3 times because of how agitated he is down in the scanner. But we do finally get it. Somehow it's a good quality study. It says no acute intracranial abnormality, some mild cerebral volume loss, age-related, kind of normal for age, and then near complete opacification of the left maxillary sinus. Please correlate clinically with acute sinusitis. And then the LP we do get. I'm just pulling up where I have it here. Okay, so he has no nucleated cells, clear fluid, um, champagne tap, no red cells, and uh, protein's normal. Glucose is like 65, 70% of serum, which is also normal. He has a full PCR, which includes E. coli K1, which is the serotype that can cause meningitis, and that's all negative. So viral etiologies, those bacterial etiologies that are common, all negative. We don't have it back during the case, but we do eventually get it back. I can say the paraneoplastic syndrome was sent because of his age and new onset, and that was negative ultimately. No autoimmune was sent. The cost was too high to justify the test. Um, and so that's that. And yeah, what I'll say the most important data point is that so you have that data kind of like that comes back at like 7 p.m. You sign this guy out as like super sick. I'm really worried about him. Like you got a gas on him in the afternoon because he's so obtunded. You're like you FI'd the MICU. Next day you come in and you're expecting some horrendous report from the intern overnight that like he went to the MICU or he's even worse. And the report you get is he is 100% back to baseline. Family thinks you are, the Lord himself, because in one 24-hour interval, you completely cured this man. So that is him the next morning. And, I guess I'm sure your mind is already there, but the issue here is that he's all the way better. And it's hard to ignore that we did a lot of things yesterday, but his LP and his MRI are generally negative, except for this weird sort of maybe sinusitis on the MRI. And I don't know, how do you reconcile that? The family asks you, you're a wizard. How'd you do it? What's wrong with my loved one?
I don't know what order we're gonna get our episodes out, but this is also some similarities to the other case of encephalopathy I presented you in terms of yeah, how to relay this to the family. So, and just like you said, it's gonna reflect my understanding of what's going on more than anything else. I would say that the negative LP showing zero cellularity is pretty reassuring. There was not bacterial meningitis because again, with the very high white count, the CRP being up, generally you see that with bacterial meningitis. So if this was florid, you would have had like pleocytosis there, right? So we don't see that. With viral encephalitis, I don't believe it's perfect sensitivity in terms of if you have lack of cellularity. It rules out something like HSV. But I would be hard pressed to say that this was just a day of acyclovir, like an HSV encephalitis just like fully turned around. I don't see any of those sorts of infectious CNS syndromes turning around immediately like this. In fact, when I think of something that really goes from 0 to 100, I mean, I think of changes to electrical activity in the brain, patients who have seizure have often have a prolonged post-ictal period. But if you don't have complete loss of consciousness, and this was like a very focal seizure for some reason, I wonder if that's why they went from 0 to 100. Delirium itself waxes and wanes quite prominently, as we said. So, would I be surprised if tomorrow the patient was worse again and this is just delirium? I wouldn't, but it's very odd that they went from 0 to 100%. Like that's not really a characteristic syndrome too. Like even with delirium, I feel like you don't go from like 0 to 100. I feel like you have these little lagging deficits. So it's so odd that it flips just 100% like this. So in terms of the underlying pathophysiology of like what was driving this brain issue, we already ruled out it wasn't a stroke, and a stroke, would have a persistent course thereafter. Um, we ruled out inflammation, like around the meninges. We can't say it's not encephalitis, but I think less likely in terms of the very rapid turnaround. Um, yeah, I'm really stuck with some sort of electrical change or some sort of like molecular change. Like what was this patient's brain exposed to that suddenly like terminated? You know what I mean? Like, did we remove something? Was this a toxic agent? The patient was on ceftriaxone when they came to the hospital. That is not neurotoxic as far as I'm aware, because we made some changes here. We switched to cefepime. We kept on metronidazole. Is there metronidazole toxicity? Is that a thing I'm not aware of? I'm not sure. But there's something about this 0 to 100% change that I think will inform on the final answer. I just don't know what it is yet, and I can't wait to hear from you if things kept evolving and this was just a fake out, or if you all figured out the final answer. Because I'm stumped. This is a great case.
Yeah, so I will say that I think we have a pretty good idea of what's going on, but it's a fun path to get there. And I suppose you could make arguments a couple different directions. So I'll be honest, we have nothing like to explain this. The only thing we have at this point in time is this MRI of, we review it with radiology, and they're like, I mean, this is like classic sinusitis. Like this is, if you showed this on a board's radiology, everyone would say this is sinusitis. But there's nothing on history, there's nothing on exam that would suggest sinusitis, which is a clinical diagnosis, of course, right? We don't treat based on imaging, we treat based on symptoms, even if the imaging is negative. But that's all you got at this point in time. And, I sort of think in my head, well, the only change we really made yesterday was that could, we normally have Augmentin, right, or anaerobic coverage, and we added that yesterday. And so I go to the family and I sort of say, listen, this would be bizarre, and in no other situation would I say that this is sinusitis, but I just don't have anything else left. And he's better. And now it becomes the challenge of like, what do we pull away and watch him off of, right? Because like we started all this stuff yesterday, and we do have to take it away now. But we don't have a good explanation of what happened, and we don't know which of these things got him better, right? And that's sort of where we're stuck. ID actually says, you got nothing else to treat except the sinusitis. Get rid of everything. Just give him Augmentin. Interestingly enough, but the the twist and the final aliquot here, the final answer is so this whole time, and really, I'll be honest, not to our knowledge, he's been having it's very minimal, but watery diarrhea, super small volume, like almost insignificant, but kind of mixed in with urine because he's confused and incontinent in bed. But finally, this same day, where we sort of have the conversation with the family about um, you know, kind of just waving our hands about sinusitis, right? None of us feel good with that diagnosis here. The nurse says, "Can we please send a C. diff?" This guy says antibiotics, and I've been, this watery diarrhea. It's not a lot. Like I think that's why you're not hearing about it because it's like no big deal from a nursing perspective. But like, do you think this is a good idea? And anyone who rounds with me knows that we do try to get them involved as much as we can. Nursing, we have them right there with us during the presentation, and so yeah, we send it and C. diff positive, toxin positive, and we peel everything off. We start him on PO Vanc, and he gets he's great. There's no change. He continues to get better. on just Vanc monotherapy, and gets discharged from the hospital a couple days later. Um, what I want to just, because I have my own postulates, but why do you think that he got better on that day that we did all of these different interventions from that day to the next?
Wow. Wow. First of all, yeah, that journey, like just of that kind of incidental, oh, the stool's coming out now. That's always like a crazy moment. But I would have definitely latched onto that given the prominence of the white count. This is classic. What I need to learn more about, and kind of I imagine you have some reflections on this in terms of your theory, is how he could have been so symptomatic from a brain perspective prior to having profound diarrhea. Anytime you have inflammation of the colon, of course, there's going to be kind of like decreased absorption of water in the colon. So therefore, you generally put out pretty high volume diarrhea, but you can get sort of like ileus from inflammation that kind of like decreases the amount of forward flow. So you can like hold on to a lot of that stool. So is this somebody who was developing image negative C. diff, meaning a lot of mucosal ulceration and kind of it was staying stagnant. He wasn't putting it out at the bedside. And was there some sort of like, I mean, there's the toxin, of course, that you excrete in the stool that we test for, but does C. diff, my question for you, have some sort of toxin that's described to go to the brain? Because clearly he was so like hyperactive from all of this. Is this something that has been described? I'm very curious. But no, my final thought, just going back to the sinusitis, is yeah, I didn't take that super seriously when he gave it to me because honestly, we get a lot of incidental kind of sinusitis on CAT scans. So I definitely saw your hesitance there and not wanting to blame that. You can get like raging bacterial sinusitis, but I agree with your assessment that since he was not very symptomatic there, that was just kind of a discordant finding. And I think the degree of the white count here was a clue, like I said earlier. Like, sure, bacterial infections like profound sepsis can cause very high white counts, but when you see that kind of like discordantly high white count, C. diff is kind of like three of the five on the top differential. So no, Mike, tell me what you learned. This is amazing case.
I think, I mean, honestly, the things I learned mostly were just, I think, okay, so I think the first thing is that initial CT scan, that CT non-con that comes in that kind of everyone rolls their eyes at because it's like, guys, we're trying to roll out Pilo here. Um, it has this read of, and again, it's not in the impression. It's just in the report above the impression. It says tubular appearance of left colon could be due to incomplete distension and or nonspecific colitis. So, I mean, right from the get-go, we had imaging that, wasn't strongly suspicious, but I'll be honest, I just my brain wasn't even looking for that clue. It was reading that report with a specific diagnosis in mind. So I just totally glossed over it. And then I seen a guy coming in and I reframed it as, recent admission with antibiotics coming back with colitis on CT scan. I think I would have immediately asked for a CDF test. But I didn't build that. I didn't put the case together in that way because my mind just totally um, breezed over that thing. And in a lot of ways, I mean, the radiologist kind of put it there, but didn't actually bring it down into the impression even. But just the first was just to read the full report very carefully and think about even the non-specific or undercalled findings as possibly being signals towards the disease you're seeing when you don't have a good diagnosis, right? This wouldn't, if you had raging pilo with an abscess, this you shouldn't focus on. But if you have nothing else, then these sort of subtle things start to become the stones to overturn. So I think that's the first big lesson for me. Just continue to be humbled in different ways. Um, I think the second is always the same. I mean, this is why I round with the nurses next to us while we're on bedside rounds because quite frankly, she clinched the diagnosis. We would not have thought to send this test. We had never heard about like voluminous diarrhea. I think that's all of our illness script for C. diff, but sort of like this slow trickle of diarrhea. It's weird. I mean, it's a completely atypical presentation where the mental status is so disproportionately out of in severity to the diarrhea itself. But that's kind of what we do on this show, right? So it's kind of like a very typical presentation of a very common, right? A classic C. diff after antibiotic course is like couldn't be more common. Um, So I think that that was too, just, do talk to the nurses. They are there every single day. They're seeing them every 2, 4 hours. This guy was in the step down unit, so literally every 2 hours, someone has eyes on them. Talk to that person, right? They're always going to have more than you will in terms of your 10-minute exam. And in terms of the like connection between C. diff and his mental status, I couldn't find anything. I mean, the C. diff toxins that we know don't, they don't do this, right? Like there's the toxin A and the toxin B, and that's what causes the colitis, the intestinal damage. But they don't cross the blood-brain barrier. They're very like local specific. They're what drive the pathophysiology of C. diff. So, I don't know. I don't know that I can blame that. Psychiatry did see him, mostly because we just needed to make sure that the guy didn't need a sitter from a safety evaluation. And they said this is just delirium. There probably was some lingering when he went home, and it was very subtle. And then this an emergence of a new hyperinflammatory condition just kind of led to, toxic metabolic encephalopathy. And what I can tell you is just I did have to look into it a little bit, but the way that C. diff causes such a profound leukocytosis, because you're exactly right. Um, like that's like one of your differentials for profound leukocytosis, particularly in a patient who otherwise doesn't look as sick. I mean, that's not this guy, but he never had a fever. He never was tachycardic. He was never hypotensive, right? So like he was never septic, even though he's profoundly confused. And so, whenever you see those things out of that's often an illness script for C. diff, right? Because if you think about like leukemoid reaction or acute leukemia, usually that's a hyperinflammatory process also. And so these people have fevers or tachycardia or hypertension for like different reasons that aren't necessarily the infection. Um, but in C. diff, basically, it causes this profound leukocytosis because it creates this profound release of cytokines. It looks like it's IL one. I'm just reading off my notes here. IL-1 beta, IL-6, and TNF alpha, and it just has to do with the local inflammation at the intestine. And the degree of leukocytosis correlates with disease severity, right? We know that. That's how we kind of one of our criteria for severe C. diff, right, is a leukocytosis, the degree of leukocytosis. And yeah, so I think it's a little bit of a hand wave, but for whatever reason, it releases these pro-inflammatory IL-1B or IL-1 beta, IL-6, and TNF alpha, and these directly signal the bone marrow to massively regulate neutrophil production and mobilization. So in some ways, it just seems to do the same thing that all infections do, but it just does it in a very targeted way because of these three cytokines that, for whatever reason, it creates or it mediates. Yeah, anytime you see a profound leukocytosis out of proportion to the rest of the lack of SIRS, I suppose, C. diff is there. So yeah, I learned a lot from the case, and it was just, I mean, very rarely do you treat someone and within 24 hours they get better. I will say, I think what happened is that on that morning we started metronidazole. And that, of course, is not like standard of care anymore, but it is treatment for C. diff, right? We used that a long time ago for that was standard. And so, well, the reason I think he got better is that that morning was the first day that he actually got directed therapy towards C. diff with that metronidazole, albeit prescribed for a completely different indication. And it was sort of almost like an afterthought, right? Like we just started him on like full meningitis. He also got dexamethasone, right? Like because he has some sort of neuroinflammatory condition. So it was kind of terrifying to pull away all of these antibiotics and just let him like, fly on PO Vanc and see how he does. Gave a lot of like sign out to the night team. But I think that's what happened. I think we accidentally started him on C. diff treatment the day before, and he got better because of that. So obviously
Oh
not what
my
you would continue.
gosh.
You'd go over to PO Vanc, but yeah, I don't know. Those are my reflections, my thoughts, teaching. I don't know. Any final thoughts from you, Andrew?
Medicine is so fun, is my only thought. Thank you for giving me reading for tomorrow. I'm going to be at case reports. I'm going to be reading case reports, looking at pseudomembranes and trying to digest C. diff a little bit. Thanks, Mike. This is so fun.
Tell me what you find.
Yeah, we'll put it on the website, guys. Take care.
Sounds good. Have a nice night, everyone. or day or whenever you listen to this. Take care.
This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.